What do you think about this electrocardiogram? What is your interpretation? Hi everyone, in the present episode, we have an EKG quiz. This electrocardiogram is taken from a 33-year-old man, presented to emergency department with sudden onset palpitation. He looks well and the hemodynamic is stable. What do you think about this strip? What is your plan? At this point, pause the video to interpret the strip on your own. Then we go over it together. As usual, to interpret every EKG tracing perfectly, use the 10-step approach. First, start with standard values. Here, the EKG speed and voltage are 25 mm per second and 10 mm per millivolt. So, this is a standard and acceptable strip. Next thing is heart rhythm. There are 3 major steps in determining every heart rhythm. First, locate and examine P-wave morphology. There are uniform P waves preceding QRS complexes. Additionally, the T waves are obviously deformed due to superimposed P waves. So, the atrial rate is about 215 beats per minute. Second, try to locate and examine QRS complex morphology. The QRS complexes are narrow and identical in this strip. So, all ventricular beats have same origin. And third, describe the relationship between the QRS complexes and P waves, using P-QRS ratio and intervals, including RR interval, PP interval, and PR interval. As we said, alternating P waves are non-conducted and superimposed on preceding T waves. So, the ratio of P to QRS complexes is 2:1. Atrial and ventricular rate are 215 and 110 beats per minute as well. Both RR intervals and PP intervals are stable. So, the underlying rhythm is regular. In summary, the rhythm is atrial tachycardia with 2:1 heart block. You might have noticed that P-wave morphology is identical to sinus beats. It is upright in D1 and D2, and slightly inverted in AVR, which is consistent with features of sinus P waves. But don't forget that, most often sinus tachycardia does not exceed 150 to 160 beats per minute in adults, unless in severe hypotension and shock. So the rhythm is not sinus tachycardia. Third step is calculating heart rate. The underlying rhythm is regular. There are 14 small boxes between consecutive R waves. So, heart rate is nearly 107 beats per minute. How about heart axis? QRS complexes are positive in D1 and D2. So, the axis is normal. Next things are examining P wave and PR interval. As we said, there are uniform P waves at rate of 215 beats per minute due to atrial tachycardia. There are alternating non-conducted P waves due to 2:1 heart block. So, there is no PR interval for dropped beats. Additionally, alternating conducted P waves have normal PR interval. Next, we have QRS complexes. As usual, examine 4 items to establish the complex changes. First is QRS duration. QRS complexes are 2 small squares and considered narrow. Second is QRS amplitude. QRS voltage is more than 10 mm in precordial leads, and more than 5 mm in LEM leads. So, the complexes are not low amplitude. None of the criteria of right or left ventricular hypertrophy is present as well. So, the complexes are neither low nor high voltage. Third item is R wave progression and transition zone. QRS complexes switch from negative to positive voltage in V3. So, the transition zone occurs in V3 and is considered normal. The last item is looking for pathologic Q waves. Fortunately, there is no pathologic Q in precordial and LEM leads. In summary, QRS complexes are totally normal. Let's go through the ST wave changes. There is no abnormal ST elevation, ST depression or T wave inversion. So, there is no abnormal ST changes in the present electrocardiogram. The 9th step is QT interval. The QT interval and heart rate are 8 small boxes and 107 beats per minute. So, according to Hodge's formula, corrected QT or QTC is about 400 milliseconds, which is within normal ranges. The last step is overall interpretation. Before going through this part, if you liked this video till now, please subscribe me and ring the bell for further videos. To make a flawless interpretation, we are supposed to make a list of abnormal findings. In this tracing, the only abnormal finding is atrial tachycardia with 2-to-1 heart block. Let's have a brief overview on atrial tachycardia. Atrial tachycardia is a regular rhythm, at a constant rate of 100 to 250 beats per minute. It originates from a single site, outside of the sinus node. The underlying mechanism of atrial tachycardia can be triggered activity, enhanced automaticity, or micro-reentry. Atrial tachycardia commonly occurs in the absence of heart disease, and has a good prognosis. On the other hand, several structural heart disease can develop atrial tachycardia. As a rule, any condition that causes atrial stretch may result in atrial tachycardia. Hypertension and cardiomyopathy of any cause are common reasons for atrial stretch. Other non-cardiac causes include infection, alcohol overdose, hypokalemia, hypoxia, drug overuse like stimulants, cocaine or digitalis toxicity. Acute management of atrial tachycardia depends on patient's clinical condition. In hemodynamically unstable patients, electrical cardioversion is our first choice to terminate arrhythmia. In stable patients like our case, intravenous adenosine, verapamil, and beta blockers can be administered for pharmacological cardioversion. Finally, in patients who are resistant to either pharmacologic or electrical cardioversion, intravenous amiodarone is the drug of choice. Thanks for watching this video. If you are eager to improve your skills in EKG interpretation, subscribe me and ring the bell. Good luck.